So we're going to talk about air embolism in neuro-ophthalmology. And as you can imagine, it is an embolus made of air. And it can be on the arterial side or it can be on the venous side. And most air emboli are iatrogenic, which means it was caused by your doctor or a nurse or whoever. And so anytime we have a needle penetrating tissue, if you hit the artery or you hit the vein, air can be introduced into there. So that's any kind of diagnostic procedures, but particularly chest procedures where you might puncture the lung or the alveoli and release the air bubble into the arterial or venous circulation. However, it can happen after surgical procedures like coronary artery bypass graft, where you're actually having to have a machine hooked up to the arterial and the venous side, or in catheter procedures like central lines, where the placement or removal of the line can allow air to enter into the internal jugular or the subclavian or whatever vein you're putting the catheter in. And normally, when you have a venous side air embolism, the vein, for example, the internal jugular vein goes to the superior vena cava, enters to the right side of the heart, and then the embolus flies into your lung. And so just like deep venous thrombosis in your leg produces pulmonary embolism, normally venous side introduction of iatrogenic air embolism just goes into the lung. So you get embolus in your lung, a pulmonary embolus. However, if you have a right to left shunt, like you have a PFO or you have a hole in your heart for whatever reason, the right-sided embolus can now fly onto the left side, go up the aorta, and enter the arterial circulation. And it turns out that it's just a straighter shot to go up the right side, even though it can go to either side, right or left. And if it goes up the right side, it can go up the right brachiocephalic, right into the carotid or into the vertebral. And that means it can present to us in ophthalmology as a loss of vision in one eye on the branch retinal artery or central retinal artery side if it's in the carotid to the ophthalmic, or if it's in the posterior circulation, it produces a homonymous hemianopsia, either right or left homonymous hemianopsia, or it can even be bilateral, and you have juxtaposed homonymous hemianopsia with cortical blindness. And it can go into the efferent side, into your brainstem. So it can cause loss of vision, double vision, one eye, two eye, homonymous, cortical blindness. And in an air embolus, what we're trying to do is reduce the size of the bubble, but also keep the bubble from going into the brain. And so the way to reduce the size of the bubble, because air is mostly nitrogen and some oxygen, by increasing the oxygen, giving 100% O2, we can drive the diffusion gradient to increase tissue oxygenation and reduce the size of this bubble because the gradient will be pulling the nitrogen out of this bubble. And so 100% oxygen should be given. Now, it's controversial about the positioning. It's, of course, going to be more common if you're having this done in the supine position because the air wants to go upstairs into your heart. And so putting the patient in the supine position or the head down or left lateral decubitus presumably would keep the air in the ventricle and not let it go upstairs because the air wants to float. In diving, this is called the bends, because the guys would come out of the diving suit and they'd be bent over because they're having air embolism. That occurs because in the ascent phase, you have to go slow because when you went to the descent phase, the pressure from the water column is pushing the gas into your blood. And then as you ascend, you get decompression sickness because the bubbles are coming out because the pressure from the water above you is less and the bubbles come out. And this happens to you every time you open a carbonated beverage too fast or pop a bottle of champagne. When you release the P, the bubbles come out. And that's Henry's law. The concentration of the bubbles is dependent, as long as the temperature is constant, on the pressure. And so the reason you need to know that for treatment of air embolism is, in addition to 100% oxygen and the positioning, we're going to use hyperbaric oxygen to increase the atmospheric pressure to drive the bubbles out. So you're trying to put them back into the solution, which is just like going back down on the diving. So both the bends and diving and air embolism in the hospital setting, whether you have an iatrogenic arterial or venous side, usually it's a non-paradoxical pulmonary embolism if you're on the venous side. But if you have a right to left shunt, you can get a paradoxical embolus. And for ophthalmologists, it means You have to act quickly on this. Positioning, 100% oxygen, hyperbaric chamber, and you got to look for the signs in the eye, retinal artery occlusion, and in the brain, homonymous hemianopsia from occipital infarct or in the brainstem diplopia.